Hello and welcome back to the Principles of Exercise Therapy. This is lecture number 4, and here we're going to be discussing the actual principles of exercise therapy. We've put this lecture on especially so that you have a detailed understanding of the principles that you need to know, not only for the module but for prescribing any exercise. The principles have been long and hard thought out. They're quite inclusive and they're very much applicable to physiotherapy. So why do we want to know about principles, I hear you ask? And the answer is that we have to start with a fundamental truth. We have to start with a baseline or a foundation or a belief system about what exercise is, and what are those underpinning or overarching principles that rule exercise. By knowing the first principles, we can then use clinical reasoning to make decisions, so that we're not just giving a particular exercise for a particular pathology. For example, McKenzie extensions for back pain or eccentric loading for Achilles tendinopathy. These would be recipes based on kind of knee-jerk reactions to what you should do for particular types of pathology without the clinical reasoning that goes behind them. So these principles really are key. So as we talked about before, we want you thinking critically, clinically reasoning what's going on with this patient, what exercise would they really benefit from, and in order to do that, we use the acronym ASPORT-BILI. And ASPORT-BILI stands, so the A is for adaptation, both mind and body changes in the efficiency of which the system works, sort of motor and physical changes. Then S stands for specificity, and this really is to do with the task. You get what you train for. So if you train for example, sprinting, you wouldn't do a load of long distance work. If you train for long distance work, you wouldn't do a load of sprinting because it's not specific to the task. Progression and regression. This is one of those things that lots of people get wrong. They either give an exercise that's too challenging for the patient or an exercise that's not challenging enough, or more likely what happens is they don't progress the exercise. The patient adapts over a 6 or 8 week period and then they're never seen again, and the exercises weren't progressed, so they can just maintain but they never get better. Overload. So the principle of overload is the drive analogy. Okay, this is the duration, the rest, the intensity, the volume, which is the combination of sets and reps together, and the energy system that we're working. So big point on overload, because that's how we train specifically for muscular strength, might be endurance or might be power. Then reversibility, use it or lose it. Exercise is something you have to maintain. If you don't maintain it, you lose all the gains that you made by doing it, and it reverses very quickly, unfortunately. Time out, rest, sleep, recovery. When we're not exercising, we need to be healing and recovering. We get the benefits of exercise not while we're doing it, but while we're recovering from it. Then we're on to behavioural change. If behaviour doesn't change, i.e. if you don't do the exercises, then you can't get the benefits. So we've got to make sure we motivate the patient. We've got to tap into their intrinsic beliefs, expectations, and values about exercise and why they're doing that. Because if we don't handle behavioral change first and foremost, we're on a hiding to nothing. Individuality. This is, rather than task specific, this is person specific. Okay, are they a tall individual? Are they a small individual? Are they previously an athlete, or are they previously not done much physical activity? Are they an amputee? Are they a wheelchair user? Are they breathless? Where do we meet the individual on the scale of ability? Next one, lifestyle integration. Here we've got to help the behavioural change into that person's lifestyle. So making sure that they're doing some sort of physical activity or exercise on a daily basis based on what they know they need to do, and make sure that that becomes a habit and that is reinforced with protected time. Then we've got law of diminishing returns. This is where better takes longer. This is the complete opposite of reversibility. So what happens, there will be a plateau where you could train someone really hard, but the gains they make are minimal. So this is what we call the rehabilitation plateau. And then lastly, we've got your responsibility. This is where the patient takes full ownership of their illness, and by doing so, they need to make sure that they're regularly exercising. Okay, so quite a detailed explanation there for all the PET principles. So moving on. As an exercise prescriber, we're going to be using clinical reasoning, not just recipes, to give the right exercise at the right time for the right patient. And this will be based on our subjective and objective assessments of the patient. So there is a paradox in exercise, and this is the prevent and provoke. So in order to prevent bad things happening in the future, such as like cardiovascular disease, stroke, cancer, diabetes, osteoarthritis, we need to make sure that we're moving and exercising. But there's a short-term provocation. We're going to get hot and sweaty and uncomfortable for a short period of time. That might be fine if you're fit and healthy, but if you're a breathless patient, for example, that's going to be a real fear and a real challenge. If you've had a bad experience with any sort of exercise or activity, again, these things can be challenging. We talk about the general adaptation stages. So the first stage is kind of alarm, the person's all stressed out. And then there's this stage where they resist a little bit. And then the next stage is one of exhaustion. So we've got to you've got to meet that person exactly where they are, or on the general adaptation stages. So let's deep dive into adaptation. So there are various systems at work here. So what we've got to do is we've got to create a stressor, and then your body's going to recognize that stress. You're either going to have a motor adaptation, i.e. the mind, or you're going to have a physiological adaptation, the body. And both will help you become more efficient. If you're younger, this is going to probably take 6 to 8 weeks. If you're older, maybe 8 to 12 weeks. Remember, motor adaptation, to do with motor fitness, physiological adaptation, obviously physical fitness. Then specificity. So we've got to be thinking about, what does the task involve? We've got to break that task down into our component parts, maybe our various functional movements. What muscle groups are we using? What energy system are we using? Is there a transfer from something the patient does previously? Okay, for example, a squat is a sit to stand, as a quick example of specificity of movement patterns. Then we've got progression and regression. This is really important. Making the exercise harder or easier is a skill in itself. It's one many physios struggle with, from what I observe. So here, for example, we've got somebody doing box squats. Okay, so they've got a kettlebell in the hand, that's providing resistance, and they're sitting down onto a box and standing up again. And then what we can do is we can progress that by taking the box away, so they haven't got the support, so they have to be in a squat position. Here, we're going to asymmetrically load on the left side if we go bottom left. And then what we can do is we can double load, so we can double the weight, thus increasing the resistance. So the classic example of progression, regression there. Overload principle, as we've covered. So this is Milo, if you've ever heard of him, the kind of mythical person in history. When he was a young boy, he used to, when a calf was born, he would lift it over his head on a regular basis. And he did that every day. And then eventually, as the calf grew, so did he, and his muscles grew to the point where he could then, press a cow up over his head. So the legend went. And that was the first discussion of progressive overload. Reversibility, this is where most of our patients will be. They'd have been fit at one stage and then they've not done their exercises through no fault of their own, or life getting in the way. And then what happens is they get this detraining effect, and with the detraining effect comes all those negative connotations: loss of bone mineral density, age-related sarcopenia, i.e. loss of muscle strength and muscle bulk, loss of fitness, and bad things happen if we're not exercising. Time out, sleep, rest and recovery, massively important. Not going to be very well serviced in a hospital environment. Lots of alarms going off, lots of people coming in and out. So people in hospital are not resting well. So if you're not sleeping, you're not recovering. And recovery strategies are very much just as important now as the exercise itself. So time out, rest and recovery, well worth thinking about, making sure we don't overtrain or indeed undertrain our patients. Behavioural change. So we've got to motivate the patient, and that's part of the therapeutic process. It is a skill within itself. We've got to talk about making every contact count, and the fact that the UCL study or the Imperial College study says 66 days to create a new habit. So on the course, we'll talk about things like motivational interviewing, making every contact count, and maybe some cognitive behavioral therapy. So making every contact count is making sure that we never miss an opportunity to give that person a little nudge, a little reminder about living a healthy lifestyle, increasing the amount of activity they do, eating healthily, making sure they're not smoking, reducing the amount they drink, and making sure that they get enough exercise and fresh air and movement and sleep, and really just that kind of behavioural change with regard towards health. We all know what good health is. Applying it is a separate skill. Individuality, respecting the individual, their age, their gender, their stage of healing, their previous health status, if they've got any comorbidities, making sure that we realise that no two patients are the same, and we respect that. Law of diminishing returns, where better takes longer. So obviously Olympic athletes might train for 4 years just to get 1 second or 0.5 of a second faster. And you eventually reach a plateau where you can't get any better. That's your rehabilitation ceiling or rehabilitation plateau. That's when we can discharge our patients to a group environment, and we've effectively done our job, and we're not going to get any better than we have done. Lifestyle integration, behavioural adaptation. This is extrinsic, physical activity becoming part of your life, joining a club, joining some sort of environment that make you accountable, protecting time to do exercise and have physical activity, maybe having a space to work out, a gym or a yoga mat or whatever it is. We've integrated that into our lifestyle. As you can see, many people are happy to take toxic pills and have surgery. Very few people wanting to change their lifestyle. And then lifestyle integration. So we make every contact count again, making sure we never miss an opportunity to get people to stop smoking, drink less, eat healthy, be active, keep a healthy weight, and then obviously thinking about mental health and well-being, hugely important in the modern world with all its multiple stresses. And then finally, it's your responsibility, i.e. you give the responsibility back to the patient. They must take full ownership of their health. Their health is their responsibility. And you can't do your exercises for your patient. And your patient needs to agree and understand that they need to continue their rehabilitation. Otherwise, it's the principle of reversibility. So this is the patient gaining control of their life and being empowered. So if we look at what we've covered the principles of exercise therapy, where we use clinical reasoning and not recipes. So which exercise are we going to use for which patient based on these principles? How long is this adaptation going to need to occur? What components of fitness, what tasks, and what goals do they want to achieve? So that's the principles. I hope you enjoyed that. See you in the next video.